To understand diabetes, we must first understand normal glucose balance, or euglycemia. In a healthy body, the pancreas acts as the regulator. When blood sugar is high, beta cells release insulin, which acts as the master key, allowing glucose to enter cells for energy. When blood sugar drops, alpha cells release glucagon, signaling the liver to break down stored glycogen and restore balance. In diabetes, this delicate balance shifts, leading to starvation in the face of plenty. Think of high blood sugar, or hyperglycemia, as a clogged pipe. Glucose is trapped in the bloodstream, unable to feed the tissues. In type 1 diabetes, the key is entirely missing due to an absolute insulin deficiency. In type 2, the key is jammed in a warped lock, representing insulin resistance. How do we differentiate the two? This master matrix breaks it down. Type 1 typically presents in patients under 30 with a rapid onset and thin habitus, driven by autoimmune destruction of beta cells. Endogenous insulin is absent, marked by HLA-DR3 or DR4 genes and low C-peptide. Type 2 is gradual, appearing in patients over 40, characterized by cellular insulin resistance and high initial C-peptide. As blood glucose rises, it triggers the clinical cascade of the 3 Ps. First, polyuria. Glucose spills into the urine, acting as an osmotic sponge that drags water with it, causing excessive urination. This fluid loss causes profound dehydration, triggering hypothalamic receptors to cause extreme thirst, or polydipsia. Finally, because cells are starving, they trigger a hypercatabolic state, causing intense hunger, or polyphagia, and weight loss. To officially diagnose diabetes, remember these 4 thresholds. Fasting plasma glucose must be at or above 126. Both the random plasma glucose with classic symptoms and the 2-hour oral glucose tolerance test must hit 200 or more. Lastly, an HbA1c of 6.5% or higher provides a historical 90-day average, unaffected by daily fluctuations. Now let's cover the acute crises. Diabetic ketoacidosis, or DKA, occurs primarily in type 1 patients. An absolute lack of insulin forces the body to burn fat for fuel, producing toxic ketone bodies. Clinically, look for deep, rapid Kussmaul respirations, a fruity acetone breath, and a high anion gap metabolic acidosis. Treat immediately with IV fluids, potassium replacement, and regular insulin. In contrast, type 2 patients are prone to hyperosmolar hyperglycemic state, or HHS. Here, trace insulin prevents fat breakdown, so there are no ketones. However, glucose skyrockets, over 600, making blood thick and hyperosmolar. This profound dehydration pulls water directly out of brain cells, causing lethargy, mental changes, or coma. Treatment requires massive IV fluid resuscitation before insulin. To quickly synthesize, DKA affects type 1 patients, has a rapid onset, and features glucose over 250, with prominent ketones and acidosis. HHS affects type 2 patients, has a gradual onset over days or weeks, and features extreme glucose, over 600, with no ketones but profound fluid loss. Recognizing these differences on exams and in the ER is critical. Moving to chronic damage. Long-term high sugar causes non-enzymatic glycation, destroying small capillaries. This leads to 3 microvascular complications. Retinopathy causes microaneurysms and fragile new vessels, risking blindness. Nephropathy features glomerulus damage and Kimmel-style Wilson nodules, with microalbuminuria as the earliest sign. Neuropathy presents as a classic stocking glove sensory loss, autonomic damage, or gastroparesis. Diabetes also accelerates macrovascular disease, causing atherosclerosis in large arteries, leading to strokes, heart attacks, and peripheral artery disease with non-healing ulcers. Behind this cell damage is the sorbitol trap. Cells convert excess glucose into sorbitol, but because certain tissues lack the enzyme to break it down, sorbitol acts as an osmotic sponge, swelling and killing cells, which causes cataracts and neuropathy. When lifestyle changes aren't enough, we turn to pharmacology. The basal bolus insulin regimen mimics natural physiology. Rapid-acting insulin, like Lispro, is taken as a mealtime bolus. Short-acting regular insulin is the only one given intravenously. Intermediate NPH is cloudy and provides basal coverage, while long-acting glargine is peakless, providing steady 24-hour basal coverage. To master these kinetics for your exams, remember the framework. Ready, set, inject, love. Rapid is ready, 15 minutes onset, 1 hour peak. Short is set, 30 minutes onset, 2 hours peak. Inject is intermediate, 2 hours onset, 8 hours peak. Love is long, 24-hour duration, no peak. And remember the mixing rule. Draw up regular, clear insulin before NPH, cloudy. Finally, for type 2 management, we use a step-up approach. Step 1 is lifestyle, targeting 15% weight loss to trigger remission. Step 2 adds metformin, which decreases hepatic glucose production. Just remember to hold it 48 hours before contrast dye. Step 3 adds GLP-1s or SGLT2s, which protect the heart and kidneys. And Step 4 initiates basal insulin if A1C remains above 9.5%. That wraps up our 6-minute clinical guide to diabetes mellitus. If you found this structured breakdown helpful, make sure to hit that subscribe button, like this video, and share it with your colleagues. See you next time on Clean Med KE.